The prostate gland is a uniquely male body part. Other than skin cancer, prostate cancer is the most common type of cancer found in American men. Prostate cancer is the second leading cause of cancer death in men, second only to lung cancer. 1 in 6 men will develop prostate cancer in his lifetime, but only 1 in 34 men will die of this disease. The death rate for prostate cancer is declining, and the disease is being discovered earlier. If you are diagnosed with prostate cancer, what are your options? This video is based on the currently available information on prostate cancer, but it is not to be used as a substitute for consultation with your physician or physicians. The goal of this presentation is to help educate you on the currently available treatment options so you can make an informed decision.
Hello, my name is Dr. Pat Fulgham. I would like to take just a few minutes to discuss with you the prostate gland and its normal anatomy and physiology. I would then like to use that information to discuss with you prostate cancer and your potential treatment options. The prostate is an accessory sexual organ which is located at the base of the urinary bladder. And although it's closely associated with the urinary tract, it's actually a reproductive organ. Its function in the normal male is to produce fluid which mixes with sperm cells and seminal vesicular fluid to comprise the ejaculate. This fluid is important in nurturing sperm in the female genital tract until fertilization can occur. The prostate is important for reproductive function but is not essential to other functions of the male genital tract, including erection and ejaculation. The prostate is very small in newborns and gradually enlarges, dramatically so at the time of puberty in response to male hormone or testosterone. As men age, the prostate gradually begins to enlarge, and this can cause classic symptoms of obstruction. These symptoms include frequency of urination, arising at night to urinate, a slow urinary stream, and dribbling at the end of urination. Prostate cancer is also a problem that tends to arise in older men. We know from studies of men in their 30s and 40s that as many as 10 to 15% of these men already have microscopic evidence of prostate cancer. However, we also know that prostate cancer is not typically diagnosed until men are in their 50s, 60s, and 70s. This implies a very slow growth pattern in most cases of prostate cancer. In fact, prostate cancer is on average the slowest growing solid tumor in men. In this graph, you can see that prostate cancer is a very slow growing malignancy in most cases. It generally takes about 90 days for one prostate cancer cell to become 2 cells, and another 90 days for 2 cells to become 4 cells, and so on. During this long period of growth, prostate cancer is gradually developing, and during that time it's less likely that the cancer will leave the prostate gland or spread. Patients and their families often ask whether prostate cancer is a malignant cancer. The word malignant merely means that prostate cancer can spread, not that it has spread. And in that sense, prostate cancer certainly is a malignant cancer. It can leave the prostate and spread to other parts of the body. But it is slow to do so, and therefore it's generally thought of as a cancer of low malignant potential. That is, it tends to spread late and to spread slowly. During this long lead-in time when prostate cancer is gradually developing, it's typically undetectable and causes few, if any, objective symptoms. As the number of prostate cancer cells increases, the likelihood that the cancer will enter the bloodstream or the lymphatic system and exit the prostate also increases. Often by the time the cancer can be felt with an examining finger, there are as many as 1 billion cells present within the prostate. However, depending on the location of the tumor, the cancer may be far advanced before it can be detected with the examining finger. It is the advent of prostate-specific antigen blood testing which has led to the ability to diagnose this disease much earlier than was previously possible. And it is precisely this ability to diagnose the disease earlier that has led to some of the difficult decisions regarding therapy. While this model describes the general behavior of prostate cancer, there are exceptions. In some cases, prostate cancer can spread early, even before it becomes detectable on rectal examination. In other cases, the prostate cancer may grow very slowly, so that a patient with prostate cancer may die of natural or unrelated causes before the prostate cancer has an opportunity to do harm. Therefore, the selection of treatment for prostate cancer depends in part on how likely it is that the prostate cancer will do harm in that individual patient. And then we must weigh the potential risk and benefits of the treatment against the potential harm of the disease. We will explore these difficult decisions in some additional detail. We are able to use some characteristics of prostate cancer to predict its overall behavior. One very important predictor of prostate cancer behavior is the prostate-specific antigen level. We know that when the prostate-specific antigen level, or PSA, is less than 10, it's unlikely that prostate cancer has spread to the skeleton. And the skeleton is the place that prostate cancer is most wont to go when it leaves the prostate gland. Therefore, when the PSA is less than 10, we are unlikely to do a bone scan to look for metastatic disease, especially if the patient has no symptoms of metastatic disease. It's therefore very important for a patient with prostate cancer to notify his physician if he has new onset of pain in the arms, back, hips, or legs. While the PSA is a very valuable tool for predicting prostate cancer behavior, it is not infallible. It is possible to have a high PSA without prostate cancer having spread. It is also possible to have a low PSA when prostate cancer has already spread. This is because as prostate cancer cells become less well differentiated, they may lose the ability to make the PSA molecule. The second factor to be considered is the amount of tumor or volume of tumor present within the prostate gland. As we alluded to earlier, it is often not possible to palpate or feel prostate cancer until at least 1 billion cancer cells are present. But this gives us only a rough estimate of the total amount of cancer within the gland. This is because prostate cancer is often what we call multifocal, or arising in different areas within the gland. And so it's possible that prostate cancer may be present in large quantities in one part of the gland and in smaller quantities in the other portion of the gland. And it's the total tumor volume that we're really interested in. Therefore, a third factor which we may consider is the number of cores which are involved with prostate cancer from the prostate biopsy. As you recall, a prostate biopsy generally involves 6 to 12 cores of tissue taken from the 2 lobes of the prostate. The pathologist will often report to us the percentage of each core which is involved with the tumor. We then use that information to try and make some predictions about how much tumor may be present in the prostate gland. When the percentage or the amount of tumor is thought to be low, that is a good prognostic finding. However, when the number of cores involved or the percentage of each core is very high, that is a less favorable prognostic finding. The fourth and one of the most useful tools we have for predicting the behavior of prostate cancer is the so-called Gleason grade. Dr. Gleason is a pathologist who determined that prostate cancer may behave in a certain way depending on the appearance of the cells themselves under the microscope. He developed a grading system which runs from 2 to 10. A Gleason grade of 2 means that the cells are very indolent in their appearance and generally grow very slowly. A Gleason grade of 10 means the cells are very undifferentiated or aggressive in their appearance and often grow very rapidly. This helps us in part predict the likelihood that treatment will be curative and also helps us to predict the subsequent course of the cancer. The majority of patients have Gleason grades of 5, 6, or 7, which is a neutral prognostic finding. A lower Gleason grade is a good prognostic finding, and a higher Gleason grade is a poorer prognostic finding. Once these factors have been evaluated for each individual patient, it's possible to make some predictions about how prostate cancer will behave. It's furthermore possible to make some predictions about how likely it is that different treatments will be curative. This combination of predictive tools is called the clinical stage, and the summary of the clinical stage is called the TNM classification system. Once the clinical stage of prostate cancer has been established for a patient, it's possible to begin a consideration of treatment options. There are basically 4 options available for the management of prostate cancer.
And he was most wonderful in explaining the options, the various options available. He also explained the type of cancer that I had in my prostate and the rate of growth, and there were so many factors. And he was talking about my age.
The first is watchful waiting, also known as expectant management. This is a strategy that's often utilized for patients who have a low likelihood that prostate cancer will progress, or who have other medical conditions which causes them to have a shortened life expectancy. Watchful waiting may be useful for patients at any age, but in general it's most useful for patients where the adverse effects of treatment outweigh the potential benefits of treatment. Observation or watchful waiting generally means frequent follow-up visits for physical examination and PSA testing. Unfortunately, there are no or few objective signs of prostate cancer progression. Therefore, there is no physical finding and no absolute value of PSA which will warn either the patient or the physician that progression has occurred. And therefore, when watchful waiting is undertaken, it's very hard to know when the cancer has progressed from organ-confined or curable to metastatic or incurable. On the other end of the treatment spectrum is hormonal ablative therapy. This is the strategy generally used when it's known that prostate cancer has already left the prostate gland and is no longer technically able to be cured. The only urologist who ever won the Nobel Prize for Medicine won it for the observation that prostate cancer can be caused to go into a type of remission when male hormone is removed. This remission generally lasts for 2 to 5 years. It is not a cure for prostate cancer. In almost every case, prostate cancer will eventually begin to grow again, but it is a very effective form of therapy. It may also sometimes be used in combinations with other therapies such as radiation or surgery. Hormonal ablative therapy may be accomplished in one of 2 ways. One way to accomplish this is to remove the testicles, which are the main source of male hormone. The other way is a chemical form of male hormone suppression administered as a shot or an implant. There are advantages and disadvantages to each of these 2 forms of treatment. Once it's been determined that prostate cancer is organ-confined or localized, consideration can be given to potentially curative treatment. There are 2 main forms of potentially curative therapy for prostate cancer. The first is local therapy without removal of the prostate. Radiation therapy is one form of local therapy based on the premise that radiation may be delivered to prostate cancer cells in such a way that prostate cancer cells are preferentially killed without harming the healthy tissue surrounding the prostate. This can be accomplished in 2 basic ways. The first is external beam therapy, and the second is the implantation of radioactive seeds or brachytherapy. External beam therapy has been used for several decades. In this form of therapy, a beam of radiation is shined from outside the patient to the prostate gland. As you can see from this anatomic drawing, external beam radiation therapy necessarily entails the delivery of radiation to healthy tissue surrounding the prostate gland. It is generally a well-tolerated treatment, and the side effects are generally mild. Recent innovations include intensity-modulated radiation therapy and image-guided radiation therapy. Using imaging, the radiation beam can be shaped and modified to minimize damage to healthy tissue. External beam radiation therapy is usually delivered in 37 treatments spread over 7 to 8 weeks. In general, the treatments are relatively painless, but not without some potential adverse side effects. There are some changes to the skin where the radiation enters the patient's body. There may be some irritation or inflammation of the bladder and the rectum associated with radiation therapy. This can result in a painful bladder syndrome called radiation cystitis. It can also result in some bleeding from the rectum called radiation proctitis. Although these complications are usually mild and limited, they can occasionally be severe and prolonged, sometimes even permanent. The risk of incontinence or urinary leakage with radiation therapy is very low. The risk of being unable to obtain an erection satisfactory for intercourse is extremely variable. For instance, if a patient already has difficulty achieving erections because of diabetes or hypertension or a combination of other diseases, it is more likely that radiation will have an adverse effect on their erectile function. The adverse effects of radiation on sexual function may become more apparent months or years after treatment. There is some evidence that patients having radiation therapy for prostate cancer may be at some increased risk for rectal carcinoma later in life. It is difficult to define a cure rate for radiation therapy, or for that matter, any treatment for localized prostate cancer. This is in part because prostate cancer grows so slowly. It may be many years before the success of any treatment can be adequately assessed. In general, radiation therapy is thought to be curative in 60 to 80% of cases. The reason there is a 20 to 40% risk of treatment failure has to do with two things. The first is the fact that prostate cancer may already be outside the prostate gland at the time of treatment. If this is true, no form of local therapy will be curative. The second has to do with the fact that not all cancer cells may be killed by the radiation therapy. The prostate gland is still in place. Therefore, cells which were present at the time of treatment may become cancerous subsequently. It appears to be true that over a 5 to 10 year period, radiation therapy may be as effective as surgery in controlling prostate cancer. Whether radiation therapy results in long-term cure or equal survivals will need to be assessed by looking at patients over a much longer period of time. The other form of commonly utilized radiation therapy is brachytherapy or radioactive seed implantation. In this form of therapy, careful anatomic studies are performed to create a virtual model of the prostate. A radiation physicist then determines the desirable dosage of radiation to be delivered and the number and distribution of seeds within the prostate gland. This is accomplished by surgical implantation of seeds through long needles inserted between the scrotum and the anus. These seeds are left in place and never removed. The seeds are radioactive for approximately 6 weeks, and at the end of that time have usually expended their radiation and become inert. The potential for cure with seed implantation is very similar to that quoted for external beam radiation therapy. The theoretical advantage of seed implantation is that there is a lower dosage of radiation delivered to the surrounding healthy tissues. On the other hand, radioactive seed implantation also carries some additional risks that are not present with external beam therapy, specifically the risk of bleeding, infection, and potential complications associated with anesthesia. In addition, the radioactive seeds may cause significant irritative and obstructive voiding complaints such as burning on urination and frequency of urination and inability to empty the bladder. If the prostate is very large, seed implantation is more technically difficult and may be less effective. Patients who have had a previous transurethral resection of the prostate for benign disease are also thought to be less desirable candidates for seed implantation. Radioactive seed implantation of the prostate is often accomplished jointly by the radiation oncologist and the urologist. Another form of radiation therapy is proton beam therapy. Proton beam therapy takes advantage of the precision with which protons release their energy. One possible advantage of proton beam is relatively fewer side effects. Cryotherapy is a form of treatment utilizing a needle inserted into the prostate to freeze the tissue. The risk of sexual dysfunction after cryotherapy is high. Other forms of local therapy, such as HIFU or high-intensity focused ultrasound, are currently being developed. Another option for the management of localized prostate cancer is complete surgical removal of the prostate. The most common operation for accomplishing this is called a radical retropubic prostatectomy. This is accomplished through an incision in the abdomen between the symphysis pubis and the umbilicus. The incision is carried to the space around the bladder, and through this incision we can reach not only the prostate but the lymph nodes in the pelvis. If the lymph nodes in the pelvis appear to be involved with cancer, then removal of the prostate gland is not curative, and the procedure will often be aborted at that point. If the lymph nodes appear to be grossly normal, then radical prostatectomy is carried out. The prostate and seminal vesicles are completely removed during radical prostatectomy. Because the urethra is an intrinsic part of the prostate in this location, a portion of the urethra is also removed. It then becomes necessary to reconnect the bladder and the urethra, and to do so in such a way that hopes to preserve continence, that is, to prevent urinary leakage. Our ability to preserve continence has improved dramatically over the last 2 decades. Nevertheless, some patients who undergo radical prostatectomy experience constant and uncontrollable leakage or complete urinary incontinence. In those cases, it may be necessary to perform a secondary surgical procedure to correct that situation. Other patients experience a milder form of incontinence called stress urinary incontinence. In these cases, external pressure applied to the bladder, such as when a patient stoops or jumps or laughs, may cause a small amount of urine to leak, necessitating the wearing of protective clothing or pads. Under certain circumstances, it may be appropriate to attempt to spare the nerves which are responsible for penile erections. These nerves are very closely applied to the lateral aspects of the prostate. The technique for attempting to preserve these nerves is called the nerve-sparing modification. There are certain clinical circumstances where attempting to preserve the nerves is not in the patient's best interest, specifically when the cancer is close to the margin of the prostate, or when there is a high-grade cancer or a large volume of tumor. It may be more appropriate to sacrifice the nerves in order to attempt to achieve clear surgical margins. This decision is highly individualized and may be discussed further at the time of consultation. In those circumstances where it is appropriate to attempt to preserve the nerves, the risk of being unable to achieve an erection after radical prostatectomy is still somewhere between 40 and 60%. In those cases where the nerves are purposely sacrificed in order to obtain clear surgical margins, the ability to obtain an erection without assistance is almost universally lost. There are a number of ways to try to facilitate the return of sexual function after radical prostatectomy. A combination of medications and techniques may be recommended for rehabilitation of sexual function after surgery. There are a number of other potential complications associated with radical prostatectomy. This is a major surgical procedure requiring a general anesthetic. Patients who wish to do so may bank 2 units of their own blood in anticipation of surgery. If the blood is not used, it is discarded. As with any major surgical procedure, there is always the risk of wound complications and anesthesia-related complications. A peculiar potential complication of pelvic surgery is the development of deep vein thrombosis, or blood clots in the legs or pelvis. This is potentially harmful because it can result in a situation where the blood clot migrates to the lung, and that can cause serious consequences, including death. You will be encouraged to walk and be active after surgery to reduce the risk of this problem. In those cases where prostate cancer has grown locally through the capsule of the prostate and into the surrounding tissue, radical removal of the prostate may not be curative. In such cases, additional therapy may be warranted, including local radiation therapy and hormonal ablative therapy. If prostate cancer has already left the prostate gland at the time of surgery, then surgery will not be curative. It may be necessary to offer additional therapy when that becomes known. While the probability of cure or complete elimination of prostate cancer is generally felt to be higher with surgery than with radiation, there is no universal agreement that surgery is more likely to produce a long-term cure than radiation therapy. Once we get to the operating room, it often takes a few minutes to get into position. But once the anesthesiologist has started the anesthetic, the procedure itself usually takes about 2 hours. During that time, we'll often call out to the family to give them an update. Most patients will remain in the hospital an average of 2 or 3 days, and most patients will wear a catheter in the bladder for about 2 weeks. You return to the office to have the catheter removed. After that, you can usually start a gradual return to full activity. It takes about 6 weeks for you to get back to your normal activity, including heavy lifting or straining. The recovery of your continence or your ability to control your urine is extremely variable, and so is the recovery of your sexual function, and that may take several months in some cases.
You're limited at first in certain activity. Accept that limit. We all do. If you have a broken arm, you're limited. When that arm heals, you gradually get it back into full use. Same thing with your lower abdomen. It's going to be very sore for a while, but that pain goes away. It's not a long-lasting thing.
The surgical therapy of prostate cancer continues to evolve. Urologists have been using laparoscopic technique for several years. This technique permits the removal of solid organs through small incisions using specialized instruments. It is possible to remove the prostate via a laparoscopic approach. There are advantages and disadvantages of this technique. In some cases, a robot may be used in conjunction with laparoscopic technique. The robot may facilitate the performance of some surgical tasks during the removal of the gland. The choice of surgical technique will depend on the preference of the individual surgeon and the characteristics of each patient. The PSA value is used to detect persistent or subsequent disease, which may occur even many years after apparently successful treatment. This video is intended to provide basic information about prostate cancer and options for treatment. It is not intended to be an exhaustive discussion of all potential risks and benefits of treatment of prostate cancer. Decisions regarding prostate cancer treatment are highly individualized and depend on many factors, including the desires and expectations of each patient. The options for treatment evolve with new technology and new understanding of the basis of the disease. We now know that about 15% of prostate cancers are genetic, and the tendency to develop prostate cancer may be inherited. It is therefore important that other male members of your immediate family be aware of that potential risk and undergo appropriate evaluation by their physician. I encourage you to ask about new approaches to treatment and to ask specific questions about your unique situation.
But if you know the options, and maybe one option seems better to you, if that is your peace of mind, counsel with your physician and see if he agrees with you or if he's trying to encourage you in another direction. I would listen to my physician.
The medical treatment of prostate cancer is only one aspect of your experience. We have a wealth of resources available for the psychological support of you and your family. These resources include literature, but also a very active support group known as Us Too. This group allows existing prostate cancer patients, their families, and prospective patients to benefit from the experience of others in dealing with prostate cancer.
There's no such thing as a dumb question when you're seeking information.
There is much to be optimistic about. Promising new treatments are on the horizon. We have made great strides in the diagnosis and treatment of prostate cancer. We look forward to working with you to overcome this disease.